All right. Let me change my name to my human name. And we are off. Okay. Well, welcome everybody. If you are new to Clinical Athlete or the Level Up Initiative or the CALU communities, and this is your first journal club, welcome. As many of you know, Clinical Athlete and Level Up have joined forces, and one of the first orders of business was to keep events like this going for our bi-weekly brain gains. So if you're not yet a member of the CALU community Facebook group, you should do that. And I'm going to put the Facebook link in the chat. It is there for you. Click that link, join that group, because we do a lot more in journal clubs, and there's some awesome stuff going on in there. And you get to stay up to date on all the CALU happenings and all the good stuff. So you can participate in these meetings in a number of ways. You can, the group, as it gets kind of a little awkward if everybody unmutes themselves at the same time and starts talking. If you have something to say, type the word comment or question in the chat, and that'll be our cue to just cue you to unmute yourself and to join the conversation. And if you unmute yourself and just start talking without doing that, we're not going to kick you out. You can also just type your comment or question. If you don't want to actually unmute yourself or turn your video on, you can just type it in the chat and we can read it off and join in the discussion. But we always encourage you to actively participate in the discussion if you can. And of course, you can just be an active listener and soak up the information. That's good too. We will do breakout rooms later on so we can get in our smaller groups and really hash things out over the topic that we're going to be discussing tonight. These meetings are always open to anybody who wants to join in. So if you've got a colleague or a friend in the field who would be interested in these things, make sure you let them know, give them the Facebook link and so they can join the party. We do record these, and the recordings will be sent to you in the coming days. They will also be housed really soon in the CALU community Facebook group, and they do go in the Clinical Athlete forum as well. And I posted the link to the paper in the chat. It's the first link that I posted above the Facebook group. So you click that link, it'll take you right to the PDF. So if you didn't have a chance to download the article before we met, you can do that now and at least follow along. And then just one more quick note on sound. If you were unmuted and then later on you're not speaking, try to just remember to mute yourself so that the background noise doesn't come through. And then otherwise you can use the chat as live discussion, just kind of like side discussion. A lot of times people will drop really handy resources and references, and there's always some great conversation going on in there. So with all of that said, welcome to the CALU Community Journal Club number 3. My name is Quinn Hennick. I am a proud clinical athlete provider, and I'm joined by Kevin McNamara, who is a physical therapist in the Seattle area. He's been a part of clinical athlete and CALU communities for a long time and is actually the one originally responsible for thinking of this journal club idea and bringing it to life. So thanks for being here as always, Kevin.
Of course, Quinn. How is everybody doing today?
I missed you, man. It's good to see you.
What do you think, man? Tom Brady, number 7, oh?
Listen, thumbs yay or nay in the chat if you're happy with the outcome of the Super Bowl last night. I like Brady. I'm gonna go yay. Man. Sorry. I don't hate greatness. Yay. Lots of yays. Oh, surprise, indifferent. Okay, that's fair. Surprising to me. See, maybe it was just getting away from Belichick. That was the real demon. Gotta respect. Yeah, Zach. And then we're also joined by our clinical athlete and CALU Journal Club intern, Megan Broussard, who is a student PT down in Texas at UT Southwestern. How are you, Megan?
I'm good. How are you?
Doing well. What'd you think of the Super Bowl? One of those? All right, that's fair.
I mean, I wasn't rooting for either team, so.
It's probably best that way. I wish I didn't care so much about sports, especially even when my team's not even playing. Like I care.
I'm a Packers fan, so we were out.
You've had like a rough, just kind of decade.
Do what?
Because you're so good every year, but then you're just not quite good enough. You know, it's one of those.
I know.
Real stinger. Megan is going to help us curate the questions, and she helps us, me and Kevin, stay on task. So we're always lucky to have Megan. So The purpose, actually, I'm going to launch our poll like I always forget to do. So just to get a feel for the room, are you a clinician, student clinician, coach trainer, or a student coach trainer? Sports ball. That's right, Jerm. It's okay, Jessica, if you don't care. It's time well spent not worrying about sports ball. I'll tell you that. Looks like we've got a lot of clinicians in the house, a lot of student clinicians as well. A few coaches and student coaches. That's cool. I'll end the poll and show you guys. Okay. So the paper that we're going to talk about, and I'll stop sharing, is titled Patient Education for Patellofemoral Pain, a Systematic Review. And they did pool some of the data. So technically it was also a little mini meta-analysis if we want to throw that in there too. But the lead author, Oliveira Silva, and this was published in the summer of last year, July 2020. And so the aim of this paper was to, in their words, evaluate the effect of education strategies combined with whatever treatment or in isolation in people with patellofemoral pain compared to other treatments. So it's pretty broad, but how does patient education do, whether it's by itself or combined with other interventions compared to other interventions? And sometimes the other intervention was also education lumped into a mix of things. So Kevin, what did you think about this paper?
Well, I mean, I'll be honest, man. So like anytime we're talking about a systematic review, we're always just kind of looking at what's the evidence kind of as a whole, kind of summarizing it, and then allowing us to kind of get an understanding of or assist in the decision-making process. So I think this paper had a lot of heterogeneity, just kind of looking at the age groups. I think it was from like 13 up to like 82. So I think it's hard to kind of take a lot of or come out with any sort of firm standing. But I did like the paper in the sense that I think it opens the discussion to something a little bit more broad, which I'm actually a little more interested in. Is there a subcategory or a subgroup of patients, or is there a population where exercise or education as a standalone is sufficient enough to kind of facilitate positive changes in whatever sort of objective outcome measure that we're monitoring? And my current position is specifically if we're talking about patellofemoral pain, because I do think there's some evidence from more the chronic pain side of stuff and low back pain where PNE as a standalone is probably not sufficient enough. But with patellofemoral pain, I do think that there probably is a population of people where some sort of healthcare provider provided education is probably sufficient enough. And I will say that with kind of the qualifier that if we're taking into account kind of what their terminal task or their end goal is. And what I mean by that is if we're talking with someone who's kind of more general population, really just having, pain with ADLs, walking or stairs or something like that, I think that especially if they've been avoiding those tasks because there's this sort of one-to-one correlation with, symptoms at the anterior knee is, correlated or aligns with tissue damage. In that case, I think education may be enough to kind of facilitate positive change for them. But if we're dealing with more of an athletic population where what they're trying to return to are, forces and stress that is going to kind of exceed or be at a higher level than what you may experience in a day-to-day scenario, I think that's probably the case where education as alone is not going to do enough for us, and some sort of structured rehab, conditioning the extensor mechanism is probably necessary. So I'd be curious to get everyone's thoughts on that, because I do think there is a subcategory or a subpopulation of people where education as a standalone may be enough for them.
I think that's a really good point. I agree. It actually, so the paper kind of refined my understanding, or at least helped me identify that there was a gap in the methodology of the studies when they're looking at patient education versus exercise versus a control, which is the gap. There's not any papers that are actually comparing it to a control. So yeah, and if anybody wants to jump in, feel free. But you can look at, if we just take kind of the data at face value, you can look at the forest plots in table or figure 3 and figure 4, and basically the conclusions or the inferences that they were drawing from the pool data that they were able to pool was that there's some, first of all, low credibility, very low credibility evidence across the board. So take everything with a grain of salt from this paper. Now, that's not the fault of the paper. The methodology is sound of this actual systematic review. It's simply that you ask the question and then you go looking for evidence, and you can only pull the evidence that you can pull based on the question that you lay out. So you can fault the authors of this paper maybe for not asking a relevant question, but I do think it's a relevant question. So sometimes the whole like garbage in, garbage out makes the systematic review itself seem bad, in that like it's bad methodology, but no, that's just kind of the state of the evidence for that particular question. But anyway, if you look at the pool data, basically what they concluded was education that's coming from the healthcare provider may be comparative to the effect that you'll get from exercise or a mix of interventions. But if you're just looking at interventions that aren't really coming from the healthcare provider in regards to an interaction, but versus here's a pamphlet on patellofemoral pain, or here's some type of like PDF that you can read through, or a booklet or something like that, that didn't seem to be as effective as exercise. Now, when you actually dig into it, there was only 3 studies that they were able to pull that were like the booklet type of information. So there was only 3 papers that even did that. And only one of them provided the information that they gave the patients. So 2 of those papers didn't even tell you or didn't show you what education they even gave them. It's just very hard to study this type of question. And then also, if you look at so you might then ask, okay, well, what are the other, because there was only 8 studies that they ended up being able to kind of analyze. They pulled 9, but then got rid of 1. So what did the other 5 studies do that it was more like patient interaction? And if you look at it in Appendix C on page 12, what's interesting to me is most of those papers are like 1 session. You have a study that's like 6 face-to-face sessions over 3 months. And the education was the nature and possible causes of patellofemoral pain, anatomy, footwear, lots of stuff. Have no idea how they structured that education. Another paper was 5 face-to-face sessions over an 8-week period. That was more of a load management educational conversation, how to modify running training based on symptoms, probably a lot of what we do. And that paper actually skewed very well towards the education side. But then when you look at 6 other papers, it was 1 session, 1 session, 1 face-to-face session, 1 face-to-face session, 1 session, 1 session. So we're saying we're educating in 1 session. Our education is in 1 session. And then when you look at those same studies and see what they did for exercise, the exercise was like multiple sessions. And I don't know if they're not talking to the person. They're not like, how are we delineating education? So I just think it's a tough it's a tough thing to study, and it's a tough thing to define. Because if you look at the Van Lingschoten paper, one of their education pieces was instructions for daily isometric quadricep contractions. So they lumped in education about an exercise that they're going to do. So it's hard to make this dichotomy, and it's not really how we practice. We're constantly we educate about various things every session. We might educate about exercise, how we do the exercises. One session we might, for whatever reason, have more of a conversation about load management. On another session, we might have a conversation about graded exposure and being okay with a little bit of symptoms. So like these things ebb and flow, session to session to session. So just kind of the way that these papers are structured, I don't know if it reflects clinical practice enough to take a lot from. Was my kind of, but then what you said, because I'm sorry if again, throw your thoughts out in the chat, anybody. I think you can press a little hand thing if you want us to unmute you too, but because what I had taken from Rich Willie's clinical practice guidelines, which we did a journal club on, we had Rich on the Clinical Athlete podcast, awesome podcast. But the big clinical practice guidelines that they came out with last year was that patellofemoral pain doesn't seem to be a self-resolving issue. It seems like something needs to kind of be done to push the needle forward, nudge the needle forward. Because I pulled Rich's paper to really kind of get a beat on that, because this particular systematic review might be saying what you said, Kevin, that maybe there is a subpopulation that will respond well to just straight education. Like they might just be fear avoidant, and you just need to tell them that, no, your knee's not going to fall off. You can do these types of things. Here's some ways to adjust, blah, blah, blah. And they can go forward. And so I pulled Rich's paper again to kind of see where the disconnect was. And I'll just kind of read in the clinical practice guidelines, they say that currently there is no evidence for RCTs to support the benefits of education compared to control, wait and see, or in addition to interventions such as exercise therapy when treating patellofemoral pain. Now, you might be like, well, this entire paper that we're talking about now is a bunch of RCTs about that very thing. But the big key is the compared to control, compared to the wait and see. That's what we're missing. It's either education compared to a bunch of other stuff, or it's education and exercise compared to education, and there's no wait and see group. And I think that's a big hole. It's hard to compare apples to apples. Tony asks, what do you guys think of the quality of the education listed in these studies? A few do reflect the pathoanatomical model of patellofemoral pain and anterior knee pain. Yeah, that's part of the kind of the heterogeneity of, it's the difficulty when you're pulling all these studies, because you're going to get lots of different ways to educate. So that's not surprising that it was just different. I can't really speak on the quality of the content necessarily, because it's so hard to actually know what was said and in the type of context it was said, but the differences are apparent, which again, kind of speaks to the profession. Like, kind of depends on what door you walk in, what type of explanation and education you're going to get. So maybe this paper is a little microcosm of the standard of care from that perspective. Steph, you're on.
Steph Sack. No, well, first off, thank you both, Kevin, Quinn. So far, great conversation. This is a really fun discussion. And Tony, that's an awesome question. I think that's something that I've reflected about, and I'd be curious to hear everyone's thoughts, where I think about Greg Lehman's like symptom modification viewpoint he did in JOSPT, where he talks about, I think, why a lot of things really work in the short term, especially pathoanatomical explanations for pain, like especially with patellofemoral pain. So like Kev was saying, like those explanations probably drive change. There's some sort of symptom modification, there's some sort of loading and graded exposure. My bias would be, I'd be curious about the potential long-term outcomes in a subset of population that might be more prone to fear avoidant type of behaviors. But it is interesting to think about those that probably do just fine with that type of education in the short term and possibly in the long term. But that's something that I've definitely grappled with as like a really kind of, I don't know, I think that's really good food for thought and a good question, Tony.
Well, some people also just do a little bit better with having an answer, even if the answer is not necessarily super empowering, or if it is very pathoanatomical.
Yeah, that's true. And Kevin, to your point about maybe there's like a subset or subpopulation that's going to do well with just education. How are we identifying that population is kind of a question to go after. Is it some type of psychosocial or, some type of like yellow flag screening?
Yeah, I think that's the hard thing, right? But I know like with the patellofemoral like practice guidelines, they talked about how there doesn't really seem to be like a self-resolution of that. And I think the point of contention I would have with that is I think we need to be more specific in kind of what populations we're talking about, because in my mind, treating someone with, anterior knee pain that is, wants to do nothing more than just get up and down the stairs, walk around, do basic ADLs. I think they're likely, this is my bias here, but I would say that providing education to them, because they're probably coming into the clinic saying like, my knee hurts, I feel like I'm doing more damage by continuing to do these things. I feel like someone in that category is likely going to be more receptive to having a positive outcome with just education, saying like, no, like this is kind of what's going on. You can kind of use an envelope of function description if you want. You've stopped doing these things, so your knees become more sensitive. It's kind of getting back into, going up and down stairs, doing basic ADLs, providing the education that they're not going to provide continual damage or harm to that person is still going to expose them to enough of a stimulus, I think, to kind of expand their envelope to where they might, come out just fine with just the education piece. I think the discussion is different if we're talking about someone that is a runner or, an athlete or someone like that who is trying to return to things that involve a lot more stress, a lot more force through the extensor mechanism. I think that population is someone that is likely not going to see a resolution or an improvement in their condition with just education. I think you need to have a little bit more of a structured rehabilitation program, just because the forces that they're imparting with that task versus an ADL or something like that is at a much higher magnitude. So there's likely going to have to be some sort of progressive structured rehabilitation versus the person who's having pain with ADLs and has maybe just stopped doing some of those things for fear of, causing damage or harm, is likely going to get enough of a stimulus to kind of return to their normal envelope of function by just completing an ADL. So in that case, I would say that education alone to that person that, you're not causing any harm, this is what's going on, the knee's sensitive, kind of return to these things under these guidelines, you should be okay. That's kind of the delineation or the distinction that I'm trying to make in terms of education alone versus education and exercise.
Jessica, you're on.
Oh yeah. I have an anecdote that sort of supports what Kevin was saying, in the sense that for like a lower level patient, I guess. Actually, a couple weeks ago, my aunt came to me and she was like, "My knee hurts. My doctor said it was patellofemoral pain," and I was like, "Okay, let me see you squat," and it was like horrible, and her she had like decreased hip abduction strength, decreased hip extension strength, and I just gave her like a little bit of education, not so much, she wasn't really fear avoidant, but she just was kind of weak, and her like form for like going downstairs for like alignment was kind of whack, and that was it. It was like 15-20 minutes, and then like 2 weeks later, and then going forward, she was like, "Jessica, like I feel so much better, like that was amazing," and I was like, "I'm a PT." But yeah, so in that sense, yeah, for like ADLs, for someone who I think just has like lack of awareness, lack of body awareness, and also like lack of strength, I think that little piece of education can go a long way. Yeah, that's all.
Going back to that Rich Willie CPG, which I'm just going to go ahead and put in the chat. So there's that paper for you too. When you open that up, it's a monster because it's like 100 pages, but a lot of that's just reference. It reads way faster than I promised. But, a lot of those patellofemoral pain and exercise studies are on not super high level people, kind of gen pop. And in a lot of those papers, it's like kind of just doing anything, whether it's quad focused or hip focused, you're just doing some exercise, imparting some type of stress to the system. And there seems to be an adaptation, crazy enough. And kind of like what Kevin said, some of those exercises that may not put a whole lot more load through the system than just basic ADLs is essentially training them up to that level of capacity, because that's what they need. And then I think this ties into Tony's question. So his question is there an argument that PTs are over treating? Potentially, but I think maybe it goes back to what Kevin says. It kind of depends on the goal. So if you read in this paper, all of the associations with patellofemoral pain, decreased activity, fear avoidant behavior, likely detraining due to, just that vicious cycle. You're more sensitive, you avoid more movement, detrain, you're detrained, so you can't tolerate as much. It just, you kind of fall off that cliff. And so if you're dealing with somebody who's got athletic goals, and especially if there's been a significant period of time where they've been dealing with something like this, it's likely that they've detrained quite a bit. So in that case, our exercise is not, we're not treating pain necessarily. What we're treating is the deconditioning factor, and we're managing the symptoms. You know, obviously I would like the symptoms to get better and the person to be more comfortable and confident, but you're kind of taking into account their functional goals, you know, in terms of the exercise intervention, and how long to draw that out, and you know, what you do with that. At least that's kind of my take.
I agree. I would say, like, especially, let's say, like, more general population, I think there's a pretty strong argument to be made that they're likely being overtreated for some of this stuff. Like you said, what is kind of the terminal task? And I would say, you know, if you have somebody that's just having some pain with stairs and stuff like that, and it's, you know, 2-3 times a week for like 6 to 8 weeks, I'd say that's probably maybe a little bit much. But again, I guess it depends on, you know, what is their current base level of conditioning, how long have they been avoiding some of these tasks, probably how long have symptoms been present is another thing to consider. But I think there's probably an argument that could be made that in a general pop situation, there probably is a little bit of overtreating going on.
Anybody have any other thoughts before we break out?
I think Jay posted something in the comment.
Oh, yeah.
Raise hand.
Jay, you're on.
Yes. So this is a question for Quinn or pretty much anyone else here, but do you know if there's been any other work that's been done kind of regarding like the different kind of treatment classifications that was posted on that CPG since it came out last year? And the reason why I ask this is because I'm wondering, you know, there are all these studies kind of like looking at PFPS, and kind of like the meta-analysis that you guys posted, it didn't come out with the, you know, for us PTs anyway, a very satisfying sort of like conclusion. I wonder how much of that is like due to just like we're lumping all patients with PFPS into, you know, patients with PFPS, but I wonder kind of like with like low back pain, if there's like different like you know, classifications, there's a lot of heterogeneity within this population that kind of might be confounding any sort of like generalized intervention that we try to do.
Jay, the short answer to your first question, has there been any papers kind of parsing out that since the CPG? I'm not aware of any. I'll throw that out to the group if you are. You know, patellofemoral pain is one of those diagnoses of exclusion. It's a pattern that we all kind of see, like this common, yeah, it kind of like hurts up under here and like this general area. And because we can't specify things beyond that, we've created at least a label that we can all now have a conversation about. But I think that's what makes it so difficult to parse that out, because the resolution is so blurry from that starting point. It's like, where would we go, you know, from there? I mean, even tendinopathies, it's really rare, at least for me, to get somebody who just like, it's that tendon pain that's only ever there perfectly in the tendon. It never like sensitizes or goes other places. And so even in those like, you know, tendinopathy, which is more tissue specific, it's usually never that clean cut. So I know that's not an answer to your question, but I think that's probably part of the difficulty is that the diagnosis itself is just hard to pin down. And I mean, even one of the papers that they included in this systematic review, I think was from like 2000. And I read the title, I didn't pull the entire paper, but the title was about anterior knee pain. It didn't even specify patellofemoral pain. And that was from an article that was 20 years ago that they included in this paper in 2020. So now we're trying to pool data from 2 decades span with very likely very different diagnostic criteria, you know, as we go. So non-answer, good question.
Yeah, Quinn, how much of this is just another one of these, when a term can mean anything, it means absolutely nothing? right? And so, I mean, we have a lot of those where we put a bucket, just here, anything that's in this goes into this bucket. And so it really can be kind of multiple presentations, multiple different meanings within that. How do we do research on something that has no fixed objective data point to go from? And I think we've got to get a better term for what we're talking about and how we differentiate that. How we do that, I don't know. But until we do that, I'm not sure that the literature is really going to be a whole lot of guidance in general, other than kind of this bland stuff.
Yeah, I think that's I mean, that's the challenge with trying to find, subcategories, right? Because there really probably are, an infinite number, because everyone's going to have, different histories, different, all sorts of qualities that come along with it. But I think, I still do like stuff like the clinical practice guidelines, because I think at the very least, even if we can't say that we're at a point right now to be able to subcategory people, it does provide us information as to at least what you should probably not be doing, right? With the clinical practice guidelines, like we know that there's low or poor evidence for this. So I think at least it allows us to have like you mentioned, Quinn, kind of a discussion and get on board with these are the things that we're all kind of in agreement that are probably not a good use of our time to build into a plan of care. So I think that's at least a step in the right direction. But with regard to kind of Jay's question on the actual subcategories, I think that'd be nice. And that's ultimately kind of the direction that we would all like to see things go. I just don't know that we'll ever actually get there for many of the reasons that Paul said, and just kind of the difference between humans in general.
On that note, let's break out, because I still think there's some things to be taken away from this, and we'll come back together. But I'm going to throw some prompts up in the chat, and Megan created these awesome prompts, so you can use them as just kind of discussion points. But let's break out and just kind of talk about what strategies we use for patient education in this demographic. This demographic being, whether we can conceptualize what patellofemoral pain really is, or just kind of this non-specific anterior knee pain, this group as a whole. What things people tend to latch onto from a model perspective or an education point perspective, what seems to work, what seems to stick, maybe what doesn't. Do you guys have, pamphlets and handouts that you use as well in conjunction with these things? And then we'll come back together and talk about it. So I'm going to nobody's going to leave. Everybody's going to stay. And I'm going to base these numbers off of that. Okay. Here we go. Okay. I always feel bad when I bring people back in case the conversations were really good. Who's got the answers? I thrive in silence.
We got so many answers.
Oh,
you're welcome. So we talked a lot about like the variability in this condition, and how we really went down the route of talking about education and what patient education actually means from this standpoint of who is your patient, what are their goals, and it's not the same as giving them education on here's what your condition is and how it's going to affect you, but instead sort of helping them walk themselves into the solution of it's task driven. So they're giving you, these are the tasks that bother me. These are the provocative activities. And then being able to walk themselves into, okay, well, what are the things that don't bother you? Or what is the threshold of pain? So that they're coming to their own conclusion. Jordan talked a lot about how patient education might not work as well for maybe your geriatric population who is just trying to return to ADLs, and they've been dealing with this for so long, and they kind of don't want to hear it because they have this model of what PT looks like, and it certainly is not just a conversation, versus other people who may be more motivated to go down different routes. And Steph also talked about kind of the variety of different avenues, like the influence of nutrition, the influence of all these other factors that play into this condition. But the moral of the story is every single patient is going to be different. And we kind of came to the conclusion that you can't approach all of them the same way, which I don't think is a new concept. Don't laugh at me, Paul.
Thank you. Yes, it's an Ebola conversation, and it does depend, Shelby. What's the depends? What's the it? No, that was awesome. Anybody else have thoughts about any of it? Maybe the common ground is establish goals. As far as the education piece, we say education. What are we talking about? We're just talking about having a conversation with the person and really getting to know them, getting to know what they think about all of it. Because there are some people that come to healthcare professional, the doctor, or whatever they want to call it, and just want to know, just want to make sure that things are not seriously wrong in some capacity. So there are some people, you might just be able to have a conversation. What would you say if I told you we're dealing with some sensitivity, but it's okay. We can work into it. It's okay if you feel it going up and down these activities. I'd actually like you to increase your activity a little bit to maybe build up a little bit of fitness to be able to do the things that you want to do. And maybe that's a light bulb moment of, oh, I can actually do this stuff. It's okay if I feel it a little bit. So there might be that subset of people that's the thing. It was they just needed that reassurance. It's just that's not going to be everybody. And like you said, Alex, sometimes the conversation about natural regression and or natural history regression to the mean, these types of things, sometimes they don't go over too well when somebody's been dealing with something for a long time, because the question is, well, okay, when's it going to regress to the mean? Because yeah.
I was just going to say, and I think with this is something that I have, and to be honest, I read this paper not anytime in the recent history, and I was just telling Paul, like, I was not planning on coming tonight, but I care about this subject because it confuses me, and I think it's really challenging. And the thing that I find to be most challenging is that when patients come to you, especially some of these highly motivated patients, they're like, I've done everything, nothing works. And I have pain all the time and it gets worse. And then I've stopped doing things because it hurts. And so I wonder, what exactly does that look like? And how do you de-escalate some of those situations? And what does patient education look like with those people to actually get them to do maybe what you want them to do, full well knowing that it might not be the thing that works, but it might be the thing that you need to identify what direction to go, if that makes sense.
I have an anecdote that may touch on it, but anybody else have any thoughts?
I hadn't thought about that, Alex. I think when it comes to somebody like that, we have to somewhat with them form a plan and establish and shape expectations for what we want the outcome of therapy to be. From my experience with folks like that, there are times when throughout our plan of care we may not get to quote unquote pain free, but if from the beginning we establish maybe getting their symptoms to a lower level where they can complete these activities for longer, I help them see that as a win, and they see that as a win. And if we instill in them the need to continue these activities for the sake of or keeping those symptoms mitigated, or throughout time, those symptoms will eventually resolve. I think instilling that in them goes a long way.
I had somebody maybe 6 months ago. He was a high level. He was a physique athlete. He was a bodybuilder, but they train legs. So he was having pretty classic patellofemoral pain. He actually got diagnosed. So he went to a physician. He went to a general practitioner who they're not versed in orthopedics. That's not their specialty, but that was the diagnosis that he got, patellofemoral pain. He came to see me, and he told me straight up, he was like, I looked up this diagnosis. I think it's BS. It doesn't tell you anything. So I'm here to get a more definitive answer. And I was like, okay, cool. But also, because in my head, because I can't necessarily on the front of the diagnostic side of things, am not necessarily going to be able to provide, I think, what he wanted, which was what's wrong with, what's the thing that's wrong with my knee that's driving the pain experience. It was very, rusty hinge on the door type of mindset. And he was an engineer, which I find is a pattern. Like, it's funny that occupations sometimes tend to drive like thought processes. Engineers tend to be very mechanically driven, at least a certain subset in my limited experience. But anyway, so I tried to reframe that and say, one of the difficulties with this, and we had the conversation about how this diagnosis is kind of based on a pain experience where I'm doing all the tests on his knee. And I said, all this stuff checks out. This is kind of dealing with a sensitive system. And that's where we throw this label on to just try to have a conversation about it. So I think what will behoove us is if we focus more on the plan, what activities you want to be able to do, how much of it you want to be able to do. In an ideal scenario, how would you be training your legs? I want to know what that would look like. So we mapped out like what his leg program day would look like. And then I helped him identify where he currently is from a capacity standpoint. And so we at least could quantify and kind of visualize this gap. It was like a whiteboard situation. It was like, here's where we want to be, here's where we are. And his question was, well, how is it that exercise is going to be kind of the fix here when exercise and training and lifting is the thing that I can't do? And I said, well, the difference is it's not going to be an all or nothing scenario. You're going to have somebody in your corner here who's going to help you make decisions of when it's okay to push forward a little bit, when we need to just pull back, but we pull back just enough to be able to continue to train, but not so much where we do nothing. And that's the whole like all or nothing cycle that he was in. So I kind of reframed how the scenario will be ever so subtly different. And because of that subtle difference in how we'll go about managing it over time, hopefully build some momentum. And that's kind of how I framed it on day one. And that conversation required multiple iterations from that point forward, which is kind of what I got, that point I was making from this paper, where it's like one education session. That's not how it works. We're talking to them all the time. And it's always, education is, there's always an opportunity to educate or rehash the conversations that you had before, so I don't know if that gets at anything there, but
I think the one thing that I would add is you do tend to see this, especially with something like patellofemoral pain, because it is kind of like that diagnosis of exclusion, to where like you can provide, all the rationale that we just laid out, and they're still just kind of not getting it. I'd say in instances like that, sometimes having a team of providers that are kind of on the same page with that, to where like if they're saying like, this doesn't make sense, whether it's consulting with, either the ortho side or something more the position related things, if you can kind of get on the same page and they're providing the same sort of narrative and rationale that you're giving to them, sometimes that's what people need to hear too, just coming from, the medical hierarchy. If it's someone from up above, the PT land that's kind of providing them with the same sort of diagnosis and narrative, I think that's can go a long way in just getting some buy-in into that initial treatment. So I think sometimes just hearing it from another source, someone that they may perceive as having more education or something like that, can go a long way in getting that person to kind of buy into what we've been talking about as well.
Do you have physicians in-house like that, Kevin? Like kind of down the hall scenario?
Yeah, like orthos like right across the hall there. Yeah.
Do you guys work things out like that? Maybe not patellofemoral pain specifically, but just in general, kind of like making sure that you guys are on the same page?
Yeah, so we have like a staff-wide meeting like every Wednesday and Friday morning. So you'll just have the ability to like go in and talk to them like, hey, like this person's, looks like patellofemoral pain. It's not really buying into the process here. I'm gonna send you down the hall, just get you an understanding of like, this is kind of what's going on. This is definitely what it is. And for the most part, hearing it from someone else is going to kind of get them over the hunch a little bit to kind of buy into that process. So I think having an environment like that can be really helpful, especially with some of those more like, I don't want to call them like difficult personalities necessarily, but someone who's just kind of like, this is kind of like bullshit. Like the guy you mentioned, Quinn. I think cases like that can sometimes really benefit from just getting a second opinion, so to speak, that aligns with what you were kind of telling them.
Cool. Thoughts from anybody else? Examples of maybe scenarios or education pieces that seemed to go over well, or maybe even some that didn't?
I want to ask advice. I'm sorry. My first language is Spanish, so I'm thinking a lot of stuff and I'm translating everything, so it's a little bit hard. But for me, it's a little bit difficult because I work with now a professional soccer team, and it's difficult when the loads are not depending on like the patient, like I feel I can't explain the patient and about the loads, but I also don't want to like speak a lot about that because I can mess up with my work with the other staff, like with the strength and conditioning staff or with the actual coach of the team. So it's a little bit hard. I feel like I need to approach them also to explain like the situation, and sometimes their way of thinking is different, like they want faster answers, like specific answers, like, okay, yeah, but she's there, it's a female soccer team, so they're like, so when is she going to get better? So if the loads like if we work the loads, what do you mean by that? Like just stop, like, okay, so she's not going to travel the next game, to see. And then like if she doesn't travel, it's like, so she rested now, is she good now? Like it's kind of hard. Does someone of you has like experience with sports teams and how to manage like the explaining that to the other staff members or the other members of the team that are not the players? I don't know if it was kind of confusing or if someone understood my point.
Makes perfect sense. Is anybody in that scenario, that team scenario where you've got these silos, sport coach, strength conditioning, and then sports med, and there's some of that going on?
I think just especially with like a diagnosis like this, I mean, coaches always are looking for a timeline, like the day after the day of the injury, after the game is over. And then when it's something that's been building up, the athlete or the patient's in this case, the athlete's been hiding it from the coach. And so they'll come to you. And so like, it's been building up and you don't even know where the source is and you don't know the timeline. And it's hard enough to try and convince the athlete of where to start. It's trying to convince a coach like, well, I need to not convince the athlete, but I need to find a starting point for the athlete. So I don't have an answer for you. Like I 100% get what you're saying. Like that's really hard. There's just a lot of politics there, I think, in that sense, because it's hard enough convincing an athlete, or I shouldn't say convincing, educating an athlete.
Well, and sometimes the hierarchy changes there, because a lot of times the sport coach kind of like, they're the top of the thing here, because we, in certain team scenarios, we say the best ability is availability. Like they just want their athletes to be healthy so they can actually play the sport. And, lowly sports med, just they get the athletes when they're hurt and they just kind of get dumped on you. So I think if you can't, this is just kind of like, I'm trying to put myself in this position. If this whole conversation about like managing training load and these types of things aren't going to go over well on the coach, at least in the short term, because they can't necessarily do that because they don't necessarily understand or whatever it is, maybe you can try to determine what aren't they getting in both their sport practice and their weight room work or strength conditioning from just a physical quality standpoint. And I'm just throwing out an example, but maybe their knee extension torque is really weak, or their knee flexion, maybe they're not getting certain things in the weight room and certain aspects of fitness in just playing the sport. And you can try to fill that gap in with whatever you're doing in the rehab process or the treatment room or something like that. Now, I don't know what that would be specifically, but that's maybe one way to think about the scenario, is that you can kind of fill in the gaps that you see and be a complement to the other, fields.
I feel like that's a double-edged sword, depending, because I feel like in sports you have to go back to a biomedical model, because to convince everyone else you kind of need numbers. Like coaches and stuff will listen to numbers more than I shouldn't say opinions, but that's really what they're looking for, is did they hit that number? Are they cleared to go? Okay, they can play. But we know for their best interest, for this pathology, that might not be the source. So it's like a tough middle ground for sure, I think.
Steph,
Oh yeah.
I was just gonna say, I think it depends. I work with some hockey players, and it kind of depends on. I talk to the player about, like, and if you're working with the team, what their goal is. Like, some players are like, I just want to make it through this tournament, and after that, I'm done with the sport, right? Like, it depends on what their goal is, and then what the coach wants out of them too. Are they in their first year of like college or university on the team, and they want to make it 4 years? Like, and explaining and educating to them that, hey, if you go back to playing now, yeah, you'll be able to play this game potentially, especially with something like patellofemoral pain, but ABCDEFG is going to happen if you don't work on it now, likely, or this is going to be the situation. So you can kind of show them a few different scenarios, and at least you're providing the education to both parties in a biomedical model, and saying, and then we can provide, like what you said, Quinn, this input. If you're not gonna change, if you're gonna go back to the game, then this is my best recommendation on your decision. But you're kind of providing them options based off of your education. That would be my recommendation, kind of what I've done before.
That's super helpful. Thank you for that.
I think too, I mean, it's really important in these situations where there seems to be like a miscommunication or a misunderstanding between like the healthcare providers and the coach and the team. I mean, I do think it's our job to provide, the best information we can and try and give them, the best opportunity for success based off what we know and what we have, like evidence-wise. But again, based off of, who you're working with, what the relationship the coach has maybe with the other medical staff. I mean, I know my short time with athletic training, at the end of the day, like the physician had the final say on if an athlete was cleared anyway. So like we would try and give them the best explanation we could to both the coach, the player, and the physician that we were working with. And then we would just document everything. So have records of what you've said, what you've talked about, making sure that kind of your ducks are in a row, just in case the coach, the physician, whoever kind of decide that, this isn't what we're going to do. We had an athlete who had been cleared, with objective markers from an ACL injury. Granted, this is, more severe. She had had surgery and waited and done everything she needed to, but psychologically, she just didn't feel like she was ready to play. But the coach wanted her to play. The physician said she was cleared. So she kind of went ahead and said, all right, I guess I have the go ahead. And she went out her next game and re-tore the ACL. Could that happen to anybody? Absolutely. But again, our education was this athlete doesn't feel ready. Like we know that there's more going into these aspects than just anatomy and just some objective markers. Like there are other things that can contribute to pain and injury. So I do think the documenting side as well is going to be extremely important, and doing your best to try and still navigate that space. Of course, not trying to lose your job or anything, but we still do have a duty to give these people the best answer we can.
Yeah, thank you, everyone. Like, I agree with everything you guys said. I don't think it's like bad communication, or they just were taught different, and it's like really hard. Like,
Oh, I think we lost Fernanda. Well, I was gonna, hopefully she can hop back on. You know, I was gonna say too, clinic in a situation like that where oh, there we go.
oh, they're lost. But just to, I don't know, throwing an idea for you guys for the CALU team, because I've been reading and trying, like, I love what you're doing, but it's a little bit hard, like maybe to do it like in the sports team, especially, you know, like maybe it would be cool to see not just like how to talk with the patient, but how to talk with coaches, with physicians, with, you know, like it would be, I would love that.
That might be its own kind of event. Get a staff on here and talk about like what a healthy staff looks like. Sport coach, strength conditioning, sports med, kind of like a round table. That would be pretty cool. If any of you are involved in a scenario like that, or know of anybody that would be interested, that would be pretty awesome. You know, Fernanda, you might in the short term, at the end of the day, that old cliche, you might end up doing something that looks kind of standard from a physical therapy standpoint. You've got this athlete for 10 minutes in the physio room or whatever it is. They've got practice. You know, their practice is going to be 2 hours long and their knees are going to hurt. But you say, okay, when do your knees hurt? When I stop and start, when I decelerate. Say, okay, well, you're going to be doing that here in about 15 minutes, but what's an exercise that can maybe prepare you for that pattern? Kind of in the short term, get the sensitivity kind of like warmed up and a little bit numbed, as they say, that exercise analgesic effect. I don't know, go over there and do a wall sit, and you're pushing your foot down and also forward into the floor. So I don't want to get too far away from just exercise prescription when we have these conversations, because we can fall down a rabbit hole of just nothing. You know, we keep pulling the onion layer back and then we're left with nothing in our hands. So there's still some things to be done here. We know that cortical inhibition with pain patterns is a thing. You're able to put less force into the area if you're also experiencing pain. It's this kind of negative feed forward. That's why isometrics sometimes are effective, because it exposes the area to enough load over this short period of time where you can now kind of get back up to your baseline at least. So all that to say is, if it's one or two things that you're giving this athlete to get good at, something super duper basic, but that puts load through that area, that you can progress a wall sit, you know, by time. You can move the foot at a different angle away from the wall to make it more kind of horizontal. These types of principles still apply. And then in the interim, you can have a conversation while they're on the wall. You know, it's okay if you feel a little bit of pain here. I actually want you to push into that a little bit to see if you can, you know, feel your muscles in your legs working, you know, with that little bit of sensitivity is okay. So you're kind of educating bit by bit as you go, knocking down some of that fear maybe that has to do, you know, that's in concordance with the pain. But I'll stop rambling there. But hopefully that was helpful. Anybody else have any thoughts overall? People are like, I gotta go to bed. It's East Coast, man. I'm over here in California.
Yeah,
I'm
we're
like,
sleeping on the East Coast.
well, this was a good one. Patellofemoral pain discussions are always going to kind of end in this silence and like shrug emoji. Megan just put the post Journal Club survey in there. So open that up before we close out so that you can give us feedback. All the changes that we've ever made to these journal clubs are based on your feedback. So that's always very, very helpful for us. We'll have the recording to you soon, and we'll be looking for topics to throw out as well. Kevin and Megan, thanks for joining us as always.
Of course, guys. Fun discussion. We're on Friday. Next one's Friday, right?
Yeah. Not this Friday, but the
Week
Friday after.
26th. Yeah.
Kevin, maybe we get you and your doc on here.
I could talk to him about it.
Talk about that, just that healthy interaction that can be helpful. But okay, thanks everyone. This was good. Appreciate everybody's input, and we see you next time.